The first person I hired was a fellow named John Tisdale, who was actually one of my fellows when I was an attending on the hematology branch. And I hired John with the idea to develop a bone marrow transplant program to treat patients with sickle cell disease. Up until now, that wasn't available. And he developed what's called a non-myeloablative transplant regimen, which was actually quite unique. Instead of using high doses of chemotherapy and radiation to completely wipe out the bone marrow and then transfuse the patient with the bone marrow or hematopoietic stem cells from a donor, an HLA-compatible donor, the goal was to make a little space in the bone marrow, not completely ablate it. So mini-transplant or non-myeloablative, or there are a number of terms for it. But it was really based upon the observation that in a number of these kids who had undergone full myeloablative bone marrow transplantation with sickle cell disease, most of them continued years later after they were cured to show 100% of their cells in their peripheral blood were of donor origin. But a small number of them, as it turns out, after a number of months to years, their own bone marrow started to come back. And so they had elements of both donor marrow function as well as recipient, their own. So that raised the possibility, well, maybe you don't have to exactly wipe out the entire bone marrow. Maybe you can use less intense regimens to open up some spaces where you can put these donor cells, because it seems like they can live together quite well.